Bleeding. Is bleeding good or bad?
Not good.
Not good. Can bleeding kill people?
Yes.
Yes. All right. So we're going to learn about the different types of bleeding that you're going to see, which are good. Well, not good, but which are really, really bad, and how to stop each different type of bleeding. All right. So I can have bleeding where? Anywhere. Yes. But one or two places. Internal or external? Am I going to see external?
Yes.
Yes. Am I going to see internal?
Yeah. Probably not.
Not really, but I can see some signs of internal bleeding, right? What are some signs of internal bleeding? Okay, so especially like in the abdominal cavity, rigidity. What?
Swelling.
Swelling. So maybe some distension.
Blood pressure declining.
So
Really bad.
maybe there's different reasons my blood pressure can drop. Discoloration, right? The accumulation of that blood. Okay, sometimes it looks like a bruise. All right, so sometimes it can be misleading, but if I have that discoloration of all of that blood accumulating, pushing up to the surface, I can see that purplish, bluish color. Okay. Do we need to go back over the cardiovascular system? Do we understand? You're like cutting it, please. Do we understand globally that the cardiovascular system is a closed circuit? So that means if we get a hole in a part of your cardiovascular system, whether it's an artery, particularly an artery, what's going to happen to that system? It's no longer closed. That blood is going to escape. And once it leaves, it doesn't come back. All right, so we got to stop it before it kills my patient. I have to go back over this. Do I need to go back over the heart anatomy for anybody? Okay. We need to go over gas exchange with anybody. Okay. Do we need to go over blood stew with anybody? Okay. Okay. Do I need to go over how the sympathetic nervous system kicks in once we start going into that initial stage of shock?
Just one more time, if you don't mind.
Okay, so if we have whatever's causing our bodies to go into a state of hypoperfusion, so particularly for this chapter, we're going to talk about bleeding, hemorrhage, all right? So once I start losing too much blood, too much fluid, the brain recognizes, hey, we're reaching some critical levels here. That brain perceives that loss of fluid or blood as a threat. So in order to preserve my life, literally, the brain says, hey, who needs to start flowing? Who needs to kick in? So epinephrine needs to start flowing in my bloodstream. So I'm going to stimulate the sympathetic nervous system and also stimulate the who? Adrenal glands to release the epinephrine. All right, what does the epinephrine do to my body? Increase my heart rate, vasoconstriction. What else? What? Bronchodilation. What else? Huh? Increased heart rate. We already said that. Increased respiratory rate. Okay. Because why are all these things happening? Particularly that vasoconstriction. Why is it happening? To shunt blood, right? My brain says, hey, arms, legs, love you. You're great. I really enjoy having you, but I can literally live without you. So we take away the majority of the blood supply to my extremities and we shunt it to who? Stuff, the things I literally can't live without, my brain, heart, and my lungs. Right? So that vasoconstrictive property is really important to make sure that that blood is shunting what blood we have left is being redirected to the vital organs and not the extremities because, you know, they're expendable. Okay? Everybody good with that? Everybody good with that? Melanie? Everyone knows the definition of perfusion. Everyone knows we gotta have it. If we don't have it, it's hypoperfusion, that is shock, and that will eventually kill us. It's easier to do this stuff than we already know. All of this stuff. Okay, so these are important numbers to understand. If we have these different types of bleeds with these different organs. And that did not make any sense. Hold on. Different organs can last longer without an adequate amount of blood supply. Okay, the most sensitive, who's going to last the least amount of time without proper blood flow, is going to be your brain and your spinal cord. Okay, 4 to 6 minutes. It's not a very long time in the grand scheme of things. Guys, other non-essential organs can last longer. Okay, so kidneys 45 minutes, muscles 2 hours, lungs 15 minutes, 15, 20 minutes. That's very generous. All right, but brain and heart are very persnickety when it comes to blood supply, because that's how we get our oxygen supply. All right, everybody good with hemorrhage? Means bleeding. Hemorrhagic shock means that you're going into a state of shock because you're bleeding out. Everybody good with that? Okay. Guys, it is important too, because part of your scene size of if you have significant blood loss is going to be what? Part of your scene size up, your general impression, if you will.
Approximating how much blood?
How much blood loss do we have on scene? All right, if it's a significant trauma, like to the point where I'm having to place a tourniquet, or even if I'm not able to place a tourniquet, I want to approximate how much blood loss my patient has. That's something you want to relay to the hospital when you call your report in. Why? So they can know if they need to go grab some blood products from pharmacy and have it on standby to give the patient in the trauma bay. Okay. Be aware that it depends on what type of surfaces you're on. It can be kind of misleading. Okay, so 100 cc's of blood spread out on this flat, non-porous tile floor will look like a lot more versus if I take 100 cc's of blood and put it on absorbent carpet. Does that make sense? This is 100 cc's is going to spread out and look more like 500 cc's on a non-porous surface. Whereas you can lose an adequate amount of blood, like if it's on carpet or like, you know, maybe in the grass or something like that, and that it's absorbed, you can't tell that much is there. So that's why we always give an approximate measurement of blood loss on the scene.
Previous slide that was the times.
The colder you are, the longer they can last. But hotter temperatures expedite the decomposition process, the dying process, all that stuff. So approximately how much blood do we have in our body? Okay, so 5 to 6 liters. Okay, when we start losing over 20% of my blood volume, not good. Okay, guys, what's 20% of 6
About a liter.
About a liter. We start seeing some significant complications. Okay, and depending on the MOI, if it's a GSW or something like that, it's very easy to lose a liter of blood in a quick manner. If you go donate blood, you typically give about half of a liter in one sitting. Okay, so that's usually the level of comfort that our bodies are okay with, losing around half a liter. It can compensate for that. Has anybody donated blood before, ever? Okay. Usually they tell you to do what after they've collected all the blood? So sit in this chair for about 10, 15 minutes. They give you fluid, they give you juice, they'll give you cookies. All right. And then they say, hey, don't go hit the gym really hard, or, you know, don't go do a bunch of yard work or anything like physically tasking. If you stand up really quick, you might get a little lightheaded, but you're not going to go into shock for losing half a liter of blood. Okay. But anything past that point, the body's like, oh, wait a minute. This is not okay. We start seeing fluctuations in vital signs. Over that liter mark, we start to see perfusion become effective. All right. So guys, we've got 3 different types of bleeding. Okay. First, and the least concerning, is going to be capillary bleeding. What is this?
finger stick from a glucometer.
Yeah,
Whatever.
a very, very, very superficial cut, right? So maybe a glucose, a lancet stick. Maybe if you pull your cuticle too far in the quick, if you get a paper cut, something very, very minimal that usually within like a minute starts clotting and it's not going to be bleeding a significant amount. Okay, so the capillary beds are busted. We don't go into the deep vasculature like the veins and the arteries. It's going to be a darker red, and it's going to what we call ooze. Yes, that is a medical term, ooze. All right, so that means it just very slowly and very consistently just kind of comes to the surface out of the injury. Okay, just like it's just a steady stream, but nice and slow, typically if it's capillary. We don't lose a lot of blood at all for capillary bleeding. How do we control that?
Band-Aid on it.
Get a 4x4, put a Band-Aid on it, right? Or get a 4x4 and just say here, hold pressure, like just pinch your finger or whatever, you know, put a little bit of pressure, a couple minutes, done, boom, bleeding stops, it's clotted already. Okay. We have venous bleeding. And that's going to be kind of the next step up, that middle ground of blood when it comes to concern. All right, what does venous bleeding look like? Okay, so it's going to be darker red, and it's going to be oozing. All right, slowly or rapidly, depending on the size of the vein. But guys, it's very important to understand the difference between venous and arterial bleeding. Is that venous blood is like a nice and slow and steady presentation. We might have a moderate or adequate amount of blood loss stemming from venous compromise, but it's just going to be a slow, steady presentation. Okay, how do we control venous bleeding?
Pressure.
So that's going to be venous bleeding, right? Yeah, we might need a bigger dressing. We might need to apply more firm pressure manually, and we might need to put a pressure dressing. If it's a very large laceration, we probably want to put a pressure dressing to control that venous bleeding with that just trauma machine, 4x4 gauzes, whatever it might be. Okay. Now, when we start to see this, we are not in good territory. Okay. Arterial bleeding is very distinct. It's going to be a much brighter red color, okay? Because what do we know about arteries? What do they do?
Carry oxygen, carry oxygenated blood to
Okay.
the tissues.
So particularly systemic, right? We're carrying that freshly oxygenated blood to the rest of the body. So the fact that it's very deeply saturated with those O2 molecules is going to give it that brighter, almost fluorescent appearance with the red. What do veins do?
Carry blood back.
They carry that deoxygenated blood back to the heart, so that's why it's going to be darker. All of the O2 molecules have kind of already been distributed. Okay, so if we have bright red bleeding, it's going to be a much brighter color, and also what's it going to do?
Spurt.
It's going
Under
to
higher
be
pressure.
spurting because it's coming from an artery, right? So guys, when we palpate a pulse, what are we touching?
An artery.
An artery, and we feel that pulsing sensation, right? The main job of an artery is to follow the commands of that left ventricle, push through at a forceful rate to provide perfusion. All right, so you will see if it is an external arterial bleed, it will literally be like squirt, pause. It will be spurting blood. And if you sit there and don't do anything about it, you can probably have a guesstimate as to what your patient's pulse rate is. Right?
Probably watch it slow down in real time.
If you're a psychopath, yeah, sure. But you're going to see it's not going to be a constant it's going to kind of like spurt, and then the intensity is going to kind of come in waves because it's acting as an artery. We're feeling that pulsating loss of blood. Okay? How do we control an arterial bleed? Tourniquet. Now guys, your sheet, your registry sheet for this, you go BSI scene safe, What do you do first? No, this is just strictly the skill.
Direct pressure, turning.
So the sheet says with a gloved hand, you're going to try to put direct manual pressure on an arterial bleed. And then you're going to say, hey, proctor, does the bleeding stop? Guys, direct pressure just with your hands is not going to stop an arterial bleed. They function under that high intense pressure normally. So it takes a lot of pressure to totally occlude an artery. All right, so for your check-off sheet, you're going to BSI and say, hey, proctor, does my bleeding stop? Nope, sure doesn't. Oh, dang. Okay, now I'm going to apply a tourniquet. You go through the steps of applying a tourniquet. Guys, in real life, if you see anything that looks like arterial blood, what are you going to do? If you see arterial bleeding,
Yep, tourniquet.
tourniquet first thing. We're not going to waste time trying to manually stop an arterial bleed. It's just not going to happen. Okay, so that's going to be a big difference between in class and what you do in real life. If you have an arterial bleed in a patient in real life, screw putting your hand on that spot, get the tourniquet out ASAP. Fair enough? Okay. Yeah. So arterial bleed is a life threat. So when you're going through these trauma assessments, hey, do I notice any life threats? If you don't ask for that, you're not going to hear me say, oh, you notice bright red spurting blood coming from your patient's right popliteal artery. Okay, guys, minutes. Patients have minutes before they bleed out for external arterial bleeds. All right, so the second you notice that, definitely life threat, get the tourniquet put on before your patient bleeds out. So this is, I believe, a pig.
I've seen this video.
They lacerate the femoral artery on a pig. So you can see how it's spurting. That's arterial bleeding. Guys, is your femoral artery large? Yes. So if was a human with a femoral artery lacerated like this significantly, I'd give them maybe 2-3 minutes. Okay.
There's a video of a guy that was mountain biking. He went over the handlebars and like right up in his groin. Lacerated his femoral artery. Like his friend was literally like hands under his leg with his knee almost like as hard as he could, and the dude was like a minute away from death.
Yeah. If you're doing any type of direct pressure for an arterial bleed, it's going to be total body weight. So like with him, like putting the knee there,
It still
like
wasn't enough.
the entire body weight has to be on. And yeah, guys, direct pressure is not going to stop an arterial bleed. So this is a pretty infamous, the guy, I think he's the goalie. He got a skate blade to the neck, lacerated his carotid artery.
Ooh.
So you can see, it's an older video, so the footage isn't super clear, but you can see how capacity the blood starts to accumulate on the ice. All right, so this is it just shows time and manner.
Captain by Barker, there's a long shot, relates to St. Louis. Shot by the left pad. Here's Barker sending him back in front now. Comes back to the line, gets it back quick. Coming up by Louder, gets it back over the line. Here's the bag, on into the Buffalo Dog, a hard road to the front of the pass. Oh, wow!
So he's already starting to lose.
Story right now with please take the camera off. Don't even bring it over there. Please. Oh my God. Just keep it away. Oh, terrible. Oh my God, what happened? You're watching Sabres Hockey Live. We're going to Sports Network. Oh.
you saw immediately that trainer got out there and put that direct pressure, I believe they had like a quick clot material, which we'll talk about in a little bit. But you've got to act immediately when we see arterial bleeds. Absolute life threat. Okay? And actually,
So like, what about the brain?
what about it?
Like if it's completely lacerated and they come in and put quick line, how long is it gonna take before he's on the table and they're there?
I mean, if they can provide supplemental oxygen and do their best to stop or slow down the bleeding,
Is he still gonna get like good perfusion? Like all of his brains?
because remember, you got two.
Yeah.
You have carotid arteries bilaterally. So hopefully it's just the one, and this one's still cooking.
So like one would kind of be enough?
And if you have immediate, like repair, definitely. All right, let's see. Y'all are gonna have to give me a minute to go through these. This is for the TCC, the tactical course that you guys can take. There are some really good videos that show
Oh my gosh.
active like arterial bleeds, but I can't remember which ones.
Left lateral chest insert.
Okay, so this is a good one too. Guys, before we watch these videos, we need to talk about tourniquets. Okay, we will go over how to apply them, but we need to talk about like what you're going to see in this video. Guys, they hurt. They don't feel good. Okay, we talked about there's almost not enough direct pressure, manual pressure in the world to stop an arterial bleed. So these things are like a blood pressure cuff on PCP. Okay. How does a tourniquet work? What's happening? Why do we put them on?
Mechanically clamping your artery against the bone.
All right. So ideally, we're trying to cut off all of the blood flow to that artery, right? Because why?
We don't want any blood going on the hole.
We don't want to lose any blood that is coming out of the hole in that artery. So we're just going to cut off the blood supply to the artery altogether so we don't continue to lose blood. Okay. So how that happens is we take these tourniquets and we are going to place them where? Anybody know?
2 inches approximately of the wound side. Or high and tight.
Technically, approximately 2 inches proximal to the injury site. So let's say the injury site's here. I'm blood spurting out here. Where am I going to place my tourniquet? Approximately 2 inches proximal. I'm going to put it on my elbow.
Above the elbow joint.
I'm going to put it on a joint. Guys, we are going to teach you guys and train you guys to place them high and tight.
Is it different on the sheet? Or we have to?
Know that it is approximately 2 inches proximal to the injury site. If you see that, that's going to be the answer.
The practical answer is unless just don't do it unless you're absolutely sure you know exactly where the wound ends.
So what about for an artery of one little turn?
Can't tourniquet somebody's neck.
As much as I would like to tourniquet some people's necks, we can't tourniquet a neck.
Yeah.
That's an airway
Okay.
obstruction.
Because guys, where can we place tourniquets?
Extremities.
Extremities only. That's the only place you can put a tourniquet. Okay, we'll talk about different things that are now within your scope for what we call junctional areas. Okay, so like a groin or up here, like in the axillary. But yeah, you can only place tourniquets on extremities. So guys, what happens? What are the arteries in nature? They have a what tone to them? How do we have vasoconstriction and vasodilation? They have a muscular tone to them, right? So if I have maybe a severed or a lacerated artery here, okay, what happens when you have a rubber band and you're pulling the rubber band taut and you cut it down the middle? What happens to the sides that are being held taut? They retract. right? That tension has been taken away. Same things happen to the artery. Okay, so if it's completely severed, if the artery lies here and it's completely severed or it's significantly lacerated right here, it's very possible that the artery could retract up to that 2 inches back from where it normally lies. Okay, so you could take the chance and place that tourniquet approximately 2 inches proximal to the injury site, but what if it retracted 3 inches and not 2? Okay, your patient's gonna die, right? So that's why we teach you guys high and tight, even if it's like a radial artery down here. I'm putting that tourniquet all the way up here because that is the only high probable chance that I am absolutely not going to question where the end of that lacerated artery lies, right? You're going to cover all of your bases if you place it high and tight. Fair enough? Question?
If it's up high, like we just try.
Go as high as you possibly can before you get to that shoulder joint. Yep. So what's a tourniquet doing? It's clamping off the blood flow to the artery. How? You said it. So pressure, yeah.
By smushing the artery against the bone.
So we're finding that artery. So this brachial artery, the pressure that I apply with the tourniquet, that circumferential pressure, it's taking all of the skin and the muscles and pushing that artery all the way up against that bone. So I am pushing my brachial artery up against my humerus. Okay, so that amount of pressure, that amount of force is pretty significant to cause that total occlusion. It doesn't feel good. Okay.
No, it does not.
Huh?
No, it does not.
It does not. Now we'll find that out. Yeah. Okay. So you're going to see in this video, I'm pretty sure this is the one it is. It's a body cam. These cops show up on scene. This woman, I believe, has already been shot or stabbed, and I think it's to the leg. But you can hear this woman when they're applying the tourniquet, she is screaming. But listen to how they talk her through it, because guys, you might have a patient, it doesn't feel good. They already obviously have an injury to that extremity to cause this arterial bleeding. And if you're causing that immense pressure, it's not going to feel good, right? You might have a patient pull away from you trying to put a tourniquet on. What do?
Stop them.
Okay, how might you do that?
Very clear. If I don't do this, he will die.
This is going to hurt like hell, but if you don't let me do it, you will literally be dead in a couple of minutes. Talk them through it. Let them know, hey, we don't have another choice here. Okay, so just realize that it is not a pleasant sensation, and that's why you hear, I'm pretty sure this is what it is, them talking her through. other people on scene, what were they doing while this person was applying the tourniquet?
Then it'll be tight.
They were trying to put as much direct manual pressure as they could while the tourniquet's being applied. Right? If it's just you and your partner, then you need to say, hey, you got manual pressure while you put the tourniquet on. It's not going to do a ton, but it's better than nothing. Okay? But yeah, you heard her screaming. It does not feel good.
What was he writing on it? Was that like?
So what was he writing?
The time you
It's
put the
hard to
tourniquet
put
on,
tourniquet on.
So yeah, guys, that's really important. You notice once he got that was not the best application of a tourniquet. Did you see how many times he was having to turn the thing? We'll talk about that a little bit later, but when he finally got it to where it was tight enough and he put that piece of Velcro over it, you write the time, you check your watch, and you write the time that it was placed. So he successfully had that tourniquet placed at 2:05, and that's what he wrote on that piece of Velcro. We'll come back to that.
What indicates that it's successful?
you can't feel pressure
No
downstream.
CRT.
We'll come back to that. We'll come back to that.
And come back and then just not refill it. So,
Why didn't you ever do that?
yeah, it did.
Okay. We are watching this video for medical purposes only. This video is not open for commentary. It's not open for soapboxes. I understand this is a sensitive video to watch with what we're currently experiencing. So this video is for medical purposes only. There is a GSW that is sustained. There is to the thigh. But I want you guys to notice, as soon as that patient goes down, all around that concrete, once that GSW is sustained, within 60 seconds, we're in bad territory. Okay, so the cop places the tourniquet on the leg, but this is to show you how quickly it can happen, and that's the sole reason we're watching this video. That's all I'm gonna say. All right, so literally after the gunshots were fired, this has been about 20 seconds, 30 seconds. Okay. The door's open. Okay, 'cause that's a lot of blood. That's a fair amount of blood. You see it coming out right here? What's happening right here?
Slipped out?
Yeah,
Was it swollen?
guys, blood is slippery. Makes things slippery. This is just another perspective. Okay, so guys, it's quick. It happens very quickly, especially if you have a larger artery that's affected, like that was a femoral artery. That was what, 60 seconds, maybe 90 seconds, and you saw how much blood was already gone. This brings up a really good point too, guys. Blood is a liquid. Once it gets on your gloves, you don't have that same traction. If you think for a second you're gonna put a tourniquet on somebody's extremity and not get blood on your gloves, and you're gonna have a great grip on that tourniquet the whole time, not gonna happen. Okay, so that's another thing to consider. That's another reason we also go high and tight, just to make sure that in the process that we're putting it on, it doesn't slip and it inches down in that place.
I saw him pull the tourniquet from his boot. Would it be a wise idea to keep it somewhere like that, or like somewhere on our person?
So you have a tourniquet in your junk bag, It's usually in the very front pocket of the jump bag. There are several medics, EMTs, who purchase their own personal tourniquet and they keep it on their belt. Yes. I have my own personal tourniquet, I keep it in my car. I got it out of my car when my husband was using the chainsaw on the tree the other weekend. I'm like, okay. Okay, guys, you can buy them online. The kind we're gonna use today and the kind that's most universally used, and it's just a very solid tourniquet. It's called a CAT tourniquet. You can find them on Amazon for about like $30 for a tourniquet. It's expensive, but.
Be careful with Amazon though. People do sell fakes. They will fail.
Or they do sell the trainers. You don't want to buy a trainer because it's been used several times, and the Velcro's not as strong.
You can also buy them direct from North American Rescue. They're the manufacturer for
That is
them.
true too.
Why would you buy them? Grady supplies monthly.
Well, you literally only have
They're
one
great.
on the truck.
Only one, really?
Yes, you have one in the jump bag.
Like, there's two extremities that are bleeding.
I understand. And that's
Okay.
why you carry this, but you also like can't take it home. Buy it.
I think I have 4 of them in different places.
One
Yeah.
for each one.
One for each
I have one.
There you go. Alright, let me see, do we wanna play here? Alright guys, so are we clear? I know we're gonna practice with a tourniquet, but signs that make our index of suspicion or our pucker factor, if you will, go through the roof when it comes to external bleeding. Everybody clear on what arterial bleed looks like, what it means? It's not good? Okay. So guys, internal bleeding, again, depending on where we're having the internal bleeding, where are some kind of hot spots to have internal bleeding? The belly, guys. There's a lot of stuff in here that can bleed, particularly who? Spleen, liver's a good culprit a lot of the times, okay? Or the pelvis, right? If we have an unstable pelvis and lacerate one of those big, like the iliac or femoral arteries. We already talked about we might see some of that rigidity, some distension, discoloration, okay? Here's a good example. This is an abdomen, okay? This is not an external bruise. This discoloration is the blood accumulating from the inside, pushing up against the skin, all right? So what if you have a patient who's unconscious, unresponsive, and you notice that purple and blue color to the belly? How can you determine if it's from an external or an internal factor? So you can maybe palpate, right? See if we have some rigidity, some distension.
Check for external hemorrhage.
Okay, guys, abdominal cavity can most of the time hold up to 1.5 liters before we start seeing significant distension. There's a bunch of nooks and crannies that blood can go sit in and hold before we start seeing that, oh shoot, we got a hot belly, is what we call it.
So they're gonna go into shock before we see that distension.
So we're typically, if it's a significant fast bleed, we're going to see signs of hypoperfusion, right? If I looked at this patient and I couldn't feel any guarding or rigidity, let me check a blood pressure. Because if it's an external bruise, doesn't mean that my patient should necessarily be in shock, right? But if it's internal blood loss presenting like this, then my pressure is probably going to reflect that state of hypoperfusion. Okay, so every assessment, every patient, every time, don't just assume, oh, this is just a bruise, they fell on something. No, actually, they could be bleeding out internally and you're not recognizing it and you're not making them a high priority patient. Okay? Guys, scene safety, all right? A lot of these arterial bleeds come from GSWs, stabbing. What else?
Car accidents.
Okay, so maybe car accidents. A lot of, okay, so maybe intentional, like a suicide attempt. A lot of machinery accidents, right? Like maybe factory settings, kitchens type thing. But yeah, if it's the machine, make sure it's what before you start trying to get to your patient? Turned off, right? So, Just make sure if it is anything like a GSW or a stabbing or anything like that, that we are 110% clear that PD is on scene, our scene is secure, the assailant's still not anywhere around our patient, okay?
What about really bad fractures? How about fractures we already
Like an open, yeah, sometimes. It's gotta be like a bilateral femoral or femur fracture that would mainly do that. All right, guys, do we manage life threats before we start looking at ABCs? So if my patient has an arterial bleed, do I really care in this exact moment that they're breathing at 30 times a minute?
No.
What am I gonna do first?
Tourniquet.
Put a tourniquet on. Once I can assure that that tourniquet is on effectively and correctly, then I'm gonna say, okay, that life threat is dealt with. Now I'm gonna start with my ABC. Fair enough? But does the ABC management change?
No.
No. If they need to be bagged, bag them. If they need an adjunct, you give it. If they need high flow O2, you give it. Shock management, all of that stuff, that's same across the board, medical or trauma. Where are these patients going? Trauma center, for sure. We're gonna do this. All right, so there are some hemostatic agents. Okay, what does this mean? So these are materials that assist in the clotting process. It expedites the clotting process. Okay, we're gonna practice doing some of this when we have our hands on time. This is just an example of, I believe this is another piggy. Sorry if I have any vegetarians out there. Yeah. So this is a substance, okay, this is a pig, this is a femoral artery, and they're purposely lacerating the femoral artery. So they're going to place, I think this is the disc, it's a disc they put inside up against the lacerated part of the artery, and it expedites and it forms a temporary clot. So you'll notice. And as they've got the disc, they're putting it directly internally, placing it right up against that artery. Once that disc is put there, you hold manual pressure for 10 minutes. All right, so that direct manual pressure for 10 minutes. I believe this is a 10-minute one. This might be a quick one. 2 minutes. Okay, so this is the quicker one. There's another one you have to hold it for 10.
Non-anesthetic, it's 10. For non-anesthetic, it's 10.
All right, so now they're taking out all of that gauze that's been saturated in the blood. And you can see the back part of the disc right here. No blood loss. Right, they're even manipulating the extremity. Okay. All right, guys, how do we control a nosebleed?
Forward.
Okay, so anybody ever had nosebleed? We do, we say pinch here, right? And then do what? This? This?
This is a 4. Yeah.
All right, so used to, they would say to lean your head back, right? To have gravity pull away from the side of the nosebleed, okay? two different things. Yeah, we don't want an airway obstruction. If that blood is trickling, there's a possibility we could aspirate it. But if we don't aspirate it, where's it gonna go? If we don't spit it out? To the stomach. Does the stomach like blood?
No.
Okay, so we might ensue vomiting. Is anyone here never thrown up in their life?
Is that a thing that happens?
I know, that's why I was seeing if anyone's gonna raise their hand. Guys, it's a pretty invasive process, right? If you get some ab workouts, it's pretty forceful. So if we've already had a clot formed, right, and we have all of that blood trickle down and then we throw up, that force can actually disrupt that clot. It can break the clot off and you can start bleeding again too. So pinch here, but lean forward. Okay, so that way any excess blood can just kind of like be spit out on the ground. We're not going to ensue vomiting or an airway obstruction.
My little brother dealt with chronic nosebleeds, like he would get several a year, and if I had a nickel for every time they shoved tampons up his nose at the urgent care clinic, I'd have a few too many nickels.
So they're not technically tampons, but they have the nose tampons in the ER because it looks the same exact. It's like yay long. It's just compressed cotton. It's got a little string on it, and they just shove it up that nostril and they just leave it there for X amount of time. And then once adequate time has passed for the clot to form, they kind of tug on the string to get it out. If you are ever at home and have a nosebleed that just won't quit, go for it. If you have access to tampons, you might want to think about like maybe cutting it in half, leave the string intact, but shove that sucker up there. Works every time.
The Army experimented with using tampons for entry wounds for gunshots.
Mm-hmm. Like literal tampons?
Basically, I'm sure they, didn't just go and pick up some Tampax, but yeah.
Well, because we had, we were doing an experimental device with a company last year, I think, last summer. It was like a tampon gun or a tampon injector. It looked like it was like a large circular plastic thing. And if you had like, especially like an open, like an abdominal penetrating trauma, you would put it up against there and you would push down, and several different looked like mini like pellet tampons. It was like the compressed gauze would be dispersed in that area. Because guys, can we put a tourniquet on the abdomen?
No.
No. All right, so we were experimenting that on the streets like a year ago.
Would it work?
Not as effectively. There was some cons when it came to once they got to OR. Yeah, it was hard to keep track of all of them, and sometimes they would be like left behind during surgery. So yeah, but yeah, there's all sorts of experimental stuff, but yeah, just an old reliable tampon, just shove it up your nostril.
Do you have to get specific consent from those patients? Like, hey, can we try this experiment?
Yes. Yes.
So I have a tampon gun I'd like to use on you.
I know you're bleeding out, but consider this.
Let's just try it. What do we got to lose, right? Okay. So guys, here's a visual, that halo test we talked about when we did the unconscious unresponsive. So this is probably not, it might not be real, but if we've got the blood here and we see that circle, see that very faint yellow fluid around the blood, that would be considered a positive halo test. All right, if I have a positive halo test, what am I dealing with? CSF, cerebral spinal fluid. I've got a significant head injury, right? Usually it means that the dura mater has been compromised. That protective, kind of like the pericardial sac that surrounds the brain, that means that it's been compromised, like lacerated or torn.
Instructor A?
Yes.
What would you do in the case of like a lot of bleeding from the nose secondary to breaking nose? Like, I mean, you're probably not gonna pinch.
Oh yeah, at that point, if we do have like maybe we have the broken bone up here at the nose, how are we gonna control that nosebleed? We're not gonna pinch. Because guys, we pinch right where that bone ends and the cartilage begins. You're pinching the cartilage together. How would we control that bleeding? externally, right? Get some 4x4 gauzes and tell them to hold it up against their nostrils, and don't apply significant pressure. Just have it held up against the nostrils.
Okay.
Okay, everybody good? Everybody ready to play? Are you sure? Okay. Questions for Zoom?